This is Tom Lee, editor-in-chief of NEJM Catalyst, and we are talking today with Giora Netzer, a critical care physician who is the vice president and chief experience officer at University of Maryland Medical System. Like any good intensivist, Giora has a very disciplined approach to medical problems. But like any good intensivist, Giora has plenty of exposure to the social issues that arise every day when you're taking care of sick patients. So it caught my interest recently when I heard him say, I'd like to ban the expression soft skills. And then he explained that there are these important interactions that we assume clinicians ought to be able to do naturally. And in truth, they need training every bit as much as they need it for procedures. And then he ticked off his top three candidates for soft skills that he'd like to turn into hard skills. Kiora, I do want to ask you to give our audience a little background on why you made this statement. But first, what are those top three soft skills that you think we need to get tough about?
Sure. So I'll define them as skills, and I think the three are first is communication, particularly discussing serious news. I think the second is conversations about goals of care, particularly in family meetings, and I think the third is our approach to interdisciplinary bedside rounding.
Well, they're great topics, and I can't wait to hear what I have not been doing right. But let me ask you about your role and how you came to identify these three areas as what we euphemistically call opportunities for improvement.
Yeah, I've got trained in pulmonary and critical care medicine, still practicing, and I think one of the things that uh, clinicians, especially in the ICU experience, is the challenges and often moral distress of caring for people who are seriously ill or even at the end of life. And what I became aware at a certain point was that I didn't have many of the skills, or I didn't have an understanding of what those skills were. And as I began to delve into it, what I realized was there was actually a really powerful body of knowledge, including impact on clinical outcomes.
Well, you won't be surprised to know that I'm not joking, that you really did make me squirm a bit because I am one of those clinicians who thinks of himself as pretty good at human interactions. But I know in my heart that I'm making it up as I go along when I do these things. And it doesn't always go great. So let's start with breaking serious news, the first of the three. If you were teaching me, how would you go about it?
So I think the first is for us to recognize that it's challenging, it's difficult, it's not instinctive for any of us. Most of us have picked up habits or approaches along the way, either from our lives outside of medicine or within healthcare, that may not be optimal. And we learn a lot of approaches like the bad news sandwich that aren't necessarily A, grounded in evidence, or B, particularly effective. So I'd say the first is that we consider a structured approach. There are more than one evidence-based structured approaches. I'm a big fan of the spikes mnemonic. I think that that's a tried and true approach that is instinctive for a lot of people once they've grasped the essentials. And really is, how do we create a structure around the discussion, just like we create a structure around everything else we do in medicine, in clinical medicine, from the physical exam onward.
And what data are there that a disciplined approach is actually helpful?
And I think the data apply two ways. And so we're first going to talk about the most important true north, which is how does it impact patients? But I think one thing when we're having this discussion that's really crucial is to acknowledge our own discomfort with doing it and the stress that it impacts upon us as clinicians. And for example, with training in discussing serious news, it reduces stress among us as caregivers. And I think that's a really key part, which is to acknowledge that we'd all like healthy, long careers at the bedside, and that we need to be able to give ourselves the tools so that we can do it consistently. In terms of outcomes, I think when we have better, there is a whole host of communication studies. And again, one of the things is there are many approaches to communication, so there's some heterogeneity when we evaluate these data. But when we look at it, is that better communication is associated with improved adherence in the ambulatory setting, that it's associated with reduced length of stay, better directing of appropriate resources in the ICU. And then when we're also providing news, we're creating less moral discomfort and perhaps less long-term anxiety and pain to our patients and families as we discuss that news.
Yeah, and I'll bet that there's less pain for the caregivers as well. I don't know if there's any data on that, but I wouldn't be surprised if that were the case.
Yeah, that's absolutely true, which is that we reduce our own anxiety in about giving the news, about giving serious news after we've been trained in how to do it.
Well, let's turn to the second procedure, the goals of care discussion, often in the context of family meetings. I have to confess that I have mainly been focused on the logistical challenges of getting those meetings arranged and then trying to show up. But I'm pretty sure you think I should have more than that on mind when I walk into those rooms.
Yeah, I got trained like so many clinicians and especially physicians, which was my training in communications. And again, I had a really rigorous academic training. Was yeah, go follow the attending in, watch how they do it, and you'll be able to do it yourself next time. And I learned some really good practices, and other ones I missed or didn't have exposure to them at all. And when I started attending, I made lots of those mistakes. And part of it was learning from colleagues who specialize in these challenging conversations like palliative care. And a lot of it was immersing in the literature and learning certain basic techniques. And again, I think one of the challenges and one of the opportunities, though, is how do we bring a structured approach into conducting a family meeting? Similarly, and when I say family meeting, that's my lens as an ICU doc. Most patients at the end of life in ICUs, over 90% of patients at the end of life in the ICU are not able to make their own decisions. So lots of my conversations happen with family members. For other clinicians, it'll be with the patient themselves. But there are structured approaches to how to discuss what our values and preferences at all stages of the care journey, including at the end of life.
And bedside rounding, what are the main points that you would make here to me and to our other colleagues?
We spend an enormous proportion of our time rounding, and yet very few of us think about it as a procedure and think about how to do it better and how to leverage the peer-reviewed literature to do so. And for interdisciplinary bedside rounding, there is a 30-year body of literature in which we know that structuring the process between the nurse and the provider and doing it at the bedside benefits all three parties and improves clinical outcomes.
Well, how are you going about teaching these skills at UMMS?
Yeah, and I think again, for me, I see the journey as how do we provide tools and how do we provide structure? Because if we simply tell people to do better, that's not a formula for success. And I think all of us are proud of the way we round. All of us take a lot of pleasure in the way that we round, but we also see the opportunities. We brought together a work group of subject matter experts and clinical stakeholders from across the system. We reviewed a really large body of literature and also looked at the experience of other healthcare systems in creating structure for interdisciplinary bedside rounds. And we created an algorithm. We identified what we thought were the most important elements, that we segmented how rounds look like into 4 parts, identified the most important elements, and created a workflow around that. And not a workflow of scripting, but a workflow of what are the important elements that are creating transparency, that are creating physical safety with the nurse and provider, closing the loop, that are creating psychological safety by doing it at the bedside and closing the loop with patient and family? And how do we build a better mousetrap?
Well, I know that learning these social skills are it's critical in this era, given the complexity of medicine. And when it doesn't go well, that it undermines patients' trust. It's demoralizing for caregivers. But when it does go well, I know this is the kind of thing that causes me, and I'm sure you to drive home feeling a bit better about how the day went. So I'm hoping that you'll continue this work and you'll look for ways to amplify your impact by sharing it through NEJM Catalyst, because I know that there's an international audience that's interested in it. So thanks for coming today, and I look forward to more from you and your colleagues on this topic.
All right, thanks so much.